any financial disclosures relative to this presentation. This is a 69-year-old Native American male who was referred to me back in 2019 by our Cherokee Indian Health Service in Oklahoma for right coronary artery CTO PCI because of class 3 angina refractory to medical therapy. The patient underwent bypass surgery back in 1997. More recent angiograms reveal a patent left intramammary artery bypass graft to left anterior descending coronary artery. All saphenous vein bypass grafts are known to be occluded. He's had patent stents extending from the left main coronary artery into the proximal left circumflex coronary artery that were actually placed by myself back in 2017. He has an RCA CTO. His ejection fraction is normal. His stress test does show high-grade ischemia in the territory of the right coronary artery. No significant past medical histories on good medical therapy. Physical exam is unremarkable. EKG did not show any Q waves. This is an angiogram of the right coronary artery CTO, just using a single guide shot. You can see it's a very proximal occlusion, about 20 to 30 millimeters long. Our dual guide catheter angiography better defined our distal vessel. I just shared this image just to point out that I initially was hoping to at least give a stab at this antegrade, but I could not get a guide catheter to actually sit in that right coronary artery for more than a few seconds beyond taking that picture. I tried with this AL1, AL.75, and JR4 guide catheters. Therefore, I knew I had to go retrograde. So I took this RAO projection to map the septals that I could try to surf through, but septal surfing did not get me where I wanted to go, so I knew I had to focus on these epicardial collaterals. Although my eyes were initially drawn to this large, tortuous epicardial collateral that goes towards the atrium, I decided to initially try the smaller, less tortuous collateral, which travels over here. So I did that by engaging the collateral initially just with a workhorse Xi'an blue wire. I chased that with a Turnpike LP microcatheter, and then I de-escalated to a SU03 guide wire, which I was able to advance across the length of that collateral into the right posterolateral artery. After bringing the Turnpike LP microcatheter across the length of the collateral, I was able to further advance my SU03 guide wire into the distal right coronary artery towards the distal cap of the CTO. Once I reached the distal cap, I was able to bring up my Turnpike LP microcatheter to the distal cap, and then I switched out for a Warrior wire, which I was able to drill through the length of the chronic total occlusion into the aorta. I then chased that with my Turnpike LP microcatheter, and once I had the Turnpike LP microcatheter in the aorta, I switched out for a Pilot 200 guide wire, which you see here. Then I snared my Pilot 200 into an antegrade JR4 guide catheter, as demonstrated here. Once I got the guide wire into the antegrade JR4 catheter, I brought my Turnpike LP microcatheter into the JR4 and removed my Pilot 200 guide wire and replaced it with an R350 guide wire. I then utilized my R350 guide wire and performed angioplasty and stenting using standard techniques. This was the angiogram after we stented the vessel. Had a good result across the length of that chronic total occlusion. When it came time to remove my retrograde gear, as suggested, I did bring my microcatheter back to the mid-circumflex, took a picture with my wire still across that collateral to make sure that there was no extravasation of contrast. I was still concerned with this picture because there was a lot of wire bias obstructing flow through that collateral, so I did take one more picture after I pulled the wire completely out just to make sure there was no perforation. This was the final result of my procedure. Great result through the length of the CTO. I did notice that the mid and distal segments of the vessel were diffusely narrowed, but I was convinced that this was due to negative remodeling due to poor perfusion for such a prolonged period of time, and I actually didn't treat it. Interestingly, that procedure was performed back in 2019. About a year ago, in 2023, the patient was referred back to me for a cardiac catheterization. He had a couple episodes of diastolic heart failure. His left-sided disease was all stable, and you can see that the right coronary artery stent is still patent, and the vessel has remodeled in a positive way. I actually did an IFR here just for academic purposes, and it was confirmed non-obstructive disease. In conclusion, although crossing small and tortuous epicardial collaterals during CTO PCI does carry increased risk, the use of modern equipment and careful technique can lead to good results in those procedures. CTO vessels are often negatively remodeled beyond the length of the CTO. After successful CTO PCI, positive remodeling will often occur gradually with time. Advanced CTO operators should refrain from treating negatively remodeled segments with stents if TIMI 3 flow is reestablished.